Good morning, students, and today we will be talking about squint or strabismus or squint, and this is our final diagnosis or final differential of the ocular deviations theme, which is the last topic that you do in this clerkship. Must be so happy and ecstatic. We're finally done with ophthalmology. Well, we have done the first two differentials, and all of these diseases involve some form of ocular deviation, and the truest form of deviation that you see truest with the word deviation is in the topic of strabismus or squint that we'll do today. This is our itinerary, or what we'll do today. We'll start off by definition. We'll start off by why we have two eyes and still see one, binocular single vision, what happens when we lose that binocular single vision, the types of strabismus, and very general overview of surgical principles of management of strabismus. So we'll start off by definition, and strabismus is defined as a condition in which the eyes do not maintain a straight alignment with one another. By straight alignment, I mean they're not orthophoric. The word ortho means straight. In simpler words, the eyes are misaligned. So what is orthophoria? Orthophoria is a normal state in which both eyes are aligned with each other. So ortho meaning straight, phoria meaning gaze. And although your eyes are horizontally displaced, they are not in the same horizontal plane. The visual system is able to take images from both eyes and is able to fuse them together to produce something called binocular single vision, which in simple terms is we have two eyes but only see one or one image. Why is that? We'll just talk about it next, and that is binocular single vision. Um, and this is the process by which visual signals from two eyes is fused into a single image. And you can do this little experiment. We do this when you are in class, but if you're doing it in online, what you do is you stick out your thumb and you block something that's about this size that can be blocked with your thumb. So a fully extended arm, stick up your thumb like a thumbs up sign and block something. If you're sitting in front of a laptop, block the logo of your laptop with one eye closed. So I've closed my left eye with my right eye. I've aligned my thumb to the logo on my laptop. Now what I do is I quickly switch between the two eyes like so, alternately close them. And what you will notice is that the thumb seems to shift in position. With the left eye closed and looking at it through the right eye, it's blocking the logo. But if I close my right eye and look at it from the left eye, I can see the logo. And that is because both of your eyes are horizontally displaced and they have a slightly different view of the world. The reason we see one is because your visual pathways and your visual system is able to fuse these two images. We'll see how that happens in a bit as well. So what is happening is you have two eyes and they look at the same object from slightly different perspectives. So both eyes are getting slightly dissimilar images of the same object, and then your visual system can fuse these two things to get these two images together to come up with one image. And this is called binocular single vision. The biggest caveat here is that the images have to be very similar to one another, slightly dissimilar. If they are different images or very dissimilar images, then the process of fusion fails. The visual system will not be able to fuse the two images. So what happens in this fusion? There are basically two processes that are involved. One is motor fusion, and that is very simple to understand. You need to first be able to move your eyes in the direction that you would want where your object of interest is, where the object that you want to see is. So motor fusion is simply your ability to move your eyes properly in all directions of gaze. And the command is issued from the motor cortex. I'm sure you know what the motor cortex is. And then its impulses go down to the extraocular muscles, which move the eye and which brings the object of your interest in front of your eyes by moving your eyes. Or if the object is already there, your eyes move to follow the object. So in either case, motor fusion is simply moving your eyes to either track your object of interest or to move your eyes towards your object of interest, or both. The other more interesting process is sensory fusion. Sensory fusion is taking slightly different images from both eyes and then processing it to make a single image. And it's the visual cortex together with other visual processing areas that is responsible for this fusion of images. And we'll see how that happens. We'll simplify it. Squint at an undergraduate level is extremely simplified because squint by itself is a very complicated topic. You have two eyes, you see one, lots of things going on. So we simplify this as much as possible. So that simplification is enough for you to gain enough competence over squint or strabismus that you can handle patients that report to you in your role as a family physician or a general practitioner. So motor fusion is simply moving your eyes towards what you want to see. So in this case, this person wants to look at this rose. So both of these eyes are converging and looking at the rose. And it's a motor cortex that issues these commands and sends it down to the extraocular muscles through the cranial nerves, third, fourth, and sixth. I'm sure you know LR6, SO4, O3. And then the eyes are moved to focus to make your eyes move towards what you want to see, and that's motor fusion. Sensory fusion is slightly more involved. And to understand sensory fusion, the first thing we need to understand is that the photoreceptors in this picture that is shown by these cylinders in both eyes, obviously there are many, many more photoreceptors than are shown in these pictures, but I'm sure you get the point. So these photoreceptors are aligned to a particular point in space. That means they each have a specific direction, and these photoreceptors always point in that direction. For example, these two photoreceptors in the right and left eyes, respectively, are pointing here and here. And similarly, every other photoreceptor is aligned to a particular point in space, and it's stimulated by light coming from that point. So this photoreceptor right here is going to be stimulated by light coming from this point because it's pointing in this direction. And this photoreceptor is going to pick up light from this point because it's pointing in this direction. So that's one thing. So photoreceptors have a certain alignment to a particular point in space. The second thing we need to understand is that you have two eyes, right? And there are pairs of photoreceptors in both eyes that are pointing towards the same point in space. For example, in this picture, in the right eye, this photoreceptor is pointing here, and in the left eye, this photoreceptor is also pointing here. So photoreceptors in both of your eyes that are pointing towards that are directed towards the same point in space, that are, in other words, aligned to the same point in space, are paired together. And they are called corresponding retinal elements. So this photoreceptor together with this photoreceptor is called a corresponding retinal element because both of them are aligned to the same point in space and they're paired to one another. And that is really important, and we'll see how that importance works out in a second. So imagine that this person wants to look at this rose, the rose that we saw in the previous picture. So that the motor fusion has worked, the eyes have converged and are pointing towards the rose. And these are your foveal photoreceptors because obviously your point of interest, the light from your point of interest always falls on your fovea. So these foveal photoreceptors are again corresponding retinal element, and these are called corresponding foveal element because they are located on the fovea. And each of these is going to receive slightly dissimilar visual input or image of this rose. And why is it slightly dissimilar? We've already talked about it because your eyes are horizontally displaced. So these corresponding foveal elements, they are corresponding foveal elements because both of them are pointing towards the same point. Both of them are aligned to the same point in space. And that point happens to be right now, is where this rose is. So these corresponding foveal elements is receiving slightly dissimilar images of this rose. And what they're going to do is they are going to send these slightly dissimilar images to a very specific point on the visual cortex. And this pathway from this corresponding foveal element to the visual cortex is fixed. It's hardwired. It's like when you press a button in your home, it always turns on the same light. It's not that you press a button and it turns on another light one day and another light another day. No, it's hardwired because the button connected to the light through the wire always remains the same. My hand is outside the field, but you get the picture. So this connection is also hardwired. So these corresponding foveal elements are going to send the slightly dissimilar images of the rose through the visual pathway to a very specific and a fixed point on the visual cortex, which are always going to be there. So this corresponding foveal element will always send the information to the part of the visual cortex that processes images from the fovea. I'll show you a picture of the visual cortex and how it is mapped to the visual field in the next slide. So now the visual cortex knows where this image is coming from, because this path is always fixed, and it knows that if the image is coming from this pathway, it must be coming from the corresponding foveal element, because this path is connected to the foveal element. And now the visual cortex knows that these slightly dissimilar images are from the same object, and they're just slightly dissimilar, and it can simply fuse them to form the picture of the rose. And this is what sensory fusion is. And the entire science behind sensory fusion is this pathway that is fixed between photoreceptors that are aligned to a particular point in space, so that the photoreceptors would only pick up light from that point A, and then they always send the information to the same point in the visual cortex, and the visual cortex knows, oh yeah, these photoreceptors are picking up light from this point in space, and they always end up here. And I know that from both of these eyes, they are sending signals from the same point, because normally they are aligned to the same point in space, the corresponding retinal elements, and I can fuse them to make one image. So this is the entire science behind sensory fusion. Sensory fusion is a little more involved, but it's not that difficult to understand once you realize photoreceptors are aligned to a particular point in space. Photoreceptors between the two eyes that are pointing or aligned to the same point in space are paired to one another and are called corresponding retinal elements. And since most of the time it is the fovea of the eye that is looking towards your object of interest, we usually speak in terms of corresponding foveal elements or corresponding foveal element. And whenever you're looking at, for example, I'm looking at the camera right now, so my corresponding foveal element is sending the image of the camera all the way back to the visual cortex, and it will always send the information to the same point in visual cortex, because the pathway is hard coded or hardwired. And that point in the visual cortex is the point where information from the fovea always comes in, or foveal corresponding foveal element. And the visual cortex knows, yeah, this information is coming from the fovea, and both the foveas are pointing in the same direction. So I know that these slightly dissimilar images can be fused together to form one image, and this is sensory fusion. So this is a map of the visual cortex of the right and left halves. This is, as you can see, the information from the foveal corresponding element or corresponding foveal element comes to the tip of the visual cortex, here and here. And the pathway between this and the corresponding foveal element is always hard fixed. It's not going to change. So the information from the fovea is also always going to end up here and here. And because these two areas are linked together, the visual cortex then can fuse these two images and show you one. That is why we have two eyes, but only see one. So motor fusion, moving your eyes, sensory fusion, processing the image to make it into one. And it's not that hard once you realize that the visual cortex already knows where the information is coming from, because the photoreceptors are always going to be pointing towards the same point in a normal person, obviously. And since most of the time it is almost always it is the fovea that is receiving light from your object of interest, that is why our eyes are always pointing towards what we see, because that allows you the best vision. We have talked about this when we were talking about refractive errors. So the corresponding foveal elements, which are the fovea of the two eyes, which are paired to one another because they are aligned to the same point in space, i.e. your object of interest, they're always going to send the information to the same point in the visual cortex, which is the tip of the visual cortex, as we just saw in the previous slide. And the brain simply takes the two slightly dissimilar images and fuses them. So now that we know what happens or how we get single vision, what happens when your eyes are no longer aligned to one another? I.e., what happens when you get a squint? You lose your binocular single vision, because the principle on which binocular single vision is based is your photoreceptors are aligned to the same point in space. And when you lose binocular single vision, the photoreceptor between the two points are no longer going, between the two eyes are no longer going to be aligned to the same point in space. So loss of binocular single vision occurs when the eyes are no longer aligned to one another, as we just mentioned, as I just mentioned, i.e. the eyes are no longer orthophoric. And this can occur either as a result of failure of motor fusion, the eyes cannot be moved properly, or a problem with sensory fusion. The visual cortex no longer receives similar info from corresponding retinal elements. So either sensory fusion is defective or motor fusion is defective. And what would happen is either because of failure of motor fusion or sensory fusion, the corresponding retinal element, and in most cases, which is going to be the corresponding foveal element, are no longer aligned to the same point in space. They're pointing in different directions. We'll see diagrammatically how that happens just in a bit. And this issue of the retinal element not being aligned leads to confusion in diplopia. Confusion happens when the corresponding retinal elements are stimulated by two different objects. And diplopia happens when you see two of one object, i.e. double vision. And we'll just see how both of those things happen in just a second. So let's see how normal fusional mechanisms work. So we have already seen this in reference to the rows. This time this person is looking at an A. So these corresponding foveal element, this and this, they are both pointing in the same direction in space. There is a hard-coded path to the part of the visual cortex which receives information from the fovea. And because the image is very similar to one another, the images coming from the two eye are very similar to one another, so that the visual cortex is able to fuse these two images and present one image to the person, because these photoreceptors are pointing or aligned to the same point in space. The photoreceptors are aligned to the same point in space. Their paths are sending impulses from the same object. The images are slightly different because the eyes are horizontally displaced from one another. They're not at the same horizontal plane. One is left of the other. So the image formed is slightly dissimilar, but the fusion is still possible because it is the same image. And the photoreceptors are aligned to the same point in space, the corresponding foveal element or corresponding retinal element, whatever you might have you. Let's talk about loss of binocular single vision. So what we'll just do is we'll turn our left eye outwards, we'll deviate it. This is called exotropia, when the eye is deviated outwards. So what has happened is that the left eye has deviated outwards and the fovea of the left eye is looking at B, while the fovea of the right eye is looking at A, and the patient or the person wants to look at A because that's where the object of interest is. It wants to look at A. So what has happened now is your corresponding foveal element are no longer aligned to the same point in space. One of the element is looking at A or aligned to A, the other element is aligned to B. So when this information travels through the visual pathway to the visual cortex, the left eye is sending image of B while the right eye is sending image of A. Two different images of two different objects, and they are very different from one another and cannot be fused. So right now your visual cortex is confused. Hey, I want my person, I want you to look at A, but I'm not getting A from both eyes. One eye is getting an A, one eye is getting a B, and you know these are A's and B's because you obviously have seen them before. So the visual cortex is confused. Am I looking at A? Am I looking at B? And because both of these information from A and B is coming from fovea, which has the best visual acuity, the brain is now really confused. Both are equally clear because both are coming from the fovea. So sometimes this person will see A, sometimes this person will see B, and that is called confusion. And that confusion occurs because the visual cortex is confused. The visual cortex is confused because different information is arriving at the same point, and that different information is arriving because the corresponding foveal element are now no longer aligned to one another, and they are sending two different images to the same point in the visual cortex, which can't be fused. So image of two different objects, A and B, from the corresponding foveal element, which is shown in green in this picture, arrive at corresponding point in the visual cortex. Everything is fine. The only thing that has gone wrong is that your corresponding foveal element are no longer aligned to the same point in space. One is looking at B, one is looking at A, which will result in confusion because these images can't be fused. They're very different from one another. So this person would sometimes see an A, sometimes see a B, because they're both equally clear. And the visual cortex is processing them as equally clear, it just can't fuse them. So sometimes you see an A, sometimes you see a B, and this is the first thing that happens when you have loss of binocular vision. This is one half of the story. The other half of the story is yet to be disclosed, and that is pretty simple to understand. There has to be some photoreceptor in the left eye that is pointing towards A now. Remember, first it was the foveal photoreceptor of both eyes, the corresponding foveal element, that were pointing towards A. It is only because the left eye has deviated outwards that the corresponding foveal element are no longer aligned to the same point in space, which is leading to confusion. But if you look carefully, there is this photoreceptor right here that is looking at this A, and it is going to take this information, this photoreceptor blue, follow its own pathway all the way back to the visual cortex, which ends up, let's say, here at this point in the visual cortex. So there are two images of A that are getting to the visual cortex, but they are ending up at different points in the visual cortex because these two images of this object are not being sent by corresponding retinal element. The image or the images of A are now being sent by unpaired retinal elements or unpaired photoreceptors to points in the visual cortex that are not corresponding to each other. So as you can see, it's a different photoreceptor as shown in blue. So it's a different corresponding retinal element. It's no longer a foveal element because the fovea of this eye is looking at B. So it's another, extrafoveal retinal element, and it's sending the information through its own pathway all the way back to the visual cortex, and it's coming in here. The right eye is fine. The foveal element is looking at A. It's following its hard-coded pathway all the way back to the visual cortex and ending up where the foveal pathway ends. But the problem is, two A's are now being sent, or images of the letter A are being sent to the visual cortex, but they are from different unpaired retinal elements, corresponding retinal element, which are not paired to one another, and also to two different places within the visual cortex. And since there is no direct connection between these two places, because they're ending up at different points on the visual cortex will perceive them as two different objects. So information of object A from unpaired and non-corresponding retinal elements, one this and the other this, arrive at their respective non-corresponding points in the visual cortex. This person is going to see two A's because A, the information is coming from unpaired, non-corresponding retinal elements. And I'm using a plural here, elements, because in reality there are two elements. This photoreceptor is part of one element. This is a part of corresponding foveal element. So now we have two A's coming up from two different unpaired, non-corresponding retinal elements, ending up at non-corresponding points on the visual cortex, which can't be fused. So the person sees two A's. And that is why as soon as you have misaligned eyes, you have confusion and you have diplopia. Confusion happens because your two foveal corresponding element are now seeing two different things. And this happens because they are no longer aligned to the same point in space because one of the eye is deviating. And in this case, one foveal element is looking at one foveal photoreceptor of the corresponding foveal element is looking at B. The other one is looking at A, and you're supposed to look at A. The left eye can't look at A because it's deviated outward for some reason, those reasons which we'll just talk about in a bit. So two different images arrive at the corresponding point in the visual cortex, which can't be fused because they're too different, and you have confusion. You have diplopia because information from the same object is arriving at two different locations on the visual cortex, and it is coming from non-paired or unpaired and non-corresponding retinal elements. And it is also ending up at two different points which are non-corresponding points on the visual cortex, and they can't be fused together because they are not linked to one another. So the visual cortex will assume there are two A's. And this is very simple to see. All you do is you press one of your eyes and you will start seeing double. And what you're doing by pressing your eye is exactly what I am showing you in this picture. Is misaligning your photoreceptors so that the appropriate alignment is not maintained. And this is why you have confusion in diplopia as soon as you lose your binocular single vision because of misaligned eyes. So this is another picture that is showing you exactly the same thing, but in a slightly different context. So this is the right eye, which is marked by an asterisk, and this is the left eye. The right eye is turned inwards now. The person wants to look at a tree, and the left eye is appropriately looking at a tree, which is good. And the information is going from the foveal photoreceptor to the appropriate part of the visual cortex. And this foveal photoreceptor is obviously a part of the foveal corresponding foveal element as it's paired to the other fovea. The problem is the other fovea is no longer aligned to the same point in space as that of the left eye, the foveal photoreceptors of the right eye. The fovea of the right eye is now pointing, the photoreceptors of the fovea of the right eye are now pointing towards the windmill. So the windmill is projected from the right eye all the way through the visual field to the part of the visual cortex that processes images from the fovea, which is at the tip of the occipital cortex. While from the left eye, which is the appropriately looking eye at the tree, projects the image of a tree. And now your visual cortex is confused because both of these are coming from the fovea. And fovea has the best visual acuity. And both of these images are equally clear. So what should I project, the tree or the windmill? So sometimes this person will see the tree, sometimes this person will see the windmill, and this is confusion. And this confusion, if you see from this picture, happens because the corresponding foveal element are no longer aligned to the same point in space. Thus, the information arriving at the corresponding point in the visual cortex is different. It's unfusable, although it's ending up at the right place, but the information is too different between the two eyes. One is looking at an A, the other is looking at a B, and it's not possible to fuse, thus you get confusion. Now, the other half is diplopia, and that's very simple to understand. There is a part of the deviating eye which is looking at the tree. It's just not the fovea, it's just another part. But this information is also going to end up on the visual cortex just at a different point from the information coming from the other eye. And since it's ending up at a different point on the visual cortex, which are non-corresponding to one another, they are not connected to one another. So the visual cortex thinks there are two ways. And since one information is coming from the fovea, that information would produce a very clear image. And the other image would be sort of blurry. And again, if you press one of your eyes, you'll notice that one image is very sharp and the other image is blurry. The blurry image is coming from the deviating eye. And if you press harder, the image would get blurrier because it will be formed further and further off from the fovea. And if you remember our discussion from the visual field, the further you get from the fovea, the worse your visual acuity or your ability to perceive detail gets. So confusion and diplopia are two things that happen when you lose your binocular single vision. So how does the brain compensate for this? Obviously, if you have confusion and diplopia, you can't simply walk around. It has to be overcome, and it is overcome by two very different processes that take place at various points in time. One is Separationscotoma, and the other is Strabismic Emblyopia. Separationscotoma is something that is very immediate. It forms within minutes of onset of deviation. Strabismic Emblyopia is something that happens later. It occurs once suppression has been around or has been active for months. Now, remember that the second part, the Emblyopia part, will only happen if your visual system is still malleable, is still in development. We have talked about Emblyopia multiple times. We talked about it when we talked about refractive errors. We also talked about it when we were talking about cataracts. And in both those cases, we were talking about a very specific age in which the visual system is malleable and can be reprogrammed. So this Emblyopia would only happen to individuals who get squint in this age group. And as you will see, most of the time, squint is a pediatric issue. It is a pediatric problem. Most of the time, you're either born with it, or it happens very close to birth, or it usually happens within the first 10 years of your life. Obviously, you can get squint later, but that squint is usually for very different reasons, as we'll talk about. It's usually a problem with movement of the eye, some form of motor failure. You can have motor failure as congenital as well, but most of the time, congenital squints are sensory squints, something wrong with sensory fusion. So right now, and I'm sure you remember this, that amblyopia can only happen, the second part of compensatory mechanism can only happen if you are at an age where the visual system can be reprogrammed, which is about less than 12 years. And this type of amblyopia is obviously called strabismic amblyopia because it's happening because of strabismus or squint. Let's talk about separationscotoma and see what happens. Separationscotoma is simply a scotoma that is formed to overcome confusion in diplopia. And what it does is it simply suppresses information coming from the deviating eye, the squinting eye. And as I said, if you gently press one of your eyes to induce diplopia, if you keep it pressed for a bit, the blurry image would disappear. And that image disappears simply because the separationscotoma sets in. You can't see it. Now, you might ask, if you were really paying attention, hey, when I press my eye, I do get diplopia, but I don't get confusion at all because, and there is a very simple answer for it, the separationscotoma that takes care of confusion forms immediately. The minute I press an eye, that scotoma is formed. And I'll just show you a picture or a diagrammatic representation that would explain this better. One very interesting characteristic of a separationscotoma is that it's only active as long as both eyes are open, the deviating eye as well as the straight eye. As soon as the patient is going to close the straight eye, the only visual stimulus getting to the visual cortex is from the deviating eye, and there is no comparison. So the separationscotoma disappears, and the patient is able to see again. So the separationscotoma is a very peculiar type of scotoma. It was only there as long as both eyes are open, and once the patient closes the good eye, the straight eye, or the orthophoric eye, the separationscotoma disappears magically, auto-magically. You don't even have to ask for a magic trick. And that happens because the visual cortex is only receiving impulse from one eye. I'll show you this to you diagrammatically as well, just the slide that's coming up. So this is where we left off our individual who had his left eye turned outwards, exotropia, and was experiencing confusion in diplopia. He was experiencing, or she was experiencing confusion because the corresponding foveal element are now sending two very dissimilar images to the same point or corresponding point on the visual cortex, which can't be fused, resulting in confusion. This person was experiencing diplopia because there are unpaired retinal elements sending information to non-corresponding points on the visual cortex, which are not connected to one another. Thus, the visual cortex of the brain thinks that there are two of those images when there is only one, leading to diplopia, because the information from the same object is ending up at two different points on the visual cortex, which are not connected to one another. Thus, the brain thinks there are two when there is actually only one, leading to double vision or diplopia. So this is what a patient is experiencing. What would happen is immediately, as soon as this process starts, the second it starts, a scotoma is going to develop over the foveal corresponding element or corresponding foveal element of the deviating eye, so that no information is received or passed on to the visual cortex, which would get rid of confusion immediately. Immediately, the minute you press your eye to induce squint, you will never experience confusion this way, simply because it is taken care of immediately. So confusion is obviated, hidden from you immediately because of formation of separationscotoma. This scotoma would extend over seconds to minutes to the point where the unpaired retinal element is sending information of the image that the other eye is also looking at, i.e. A in this case, to get rid of diplopia. Diplopia takes a little bit of time, seconds to minutes, but confusion is gone immediately. Because it takes a little bit of time because the separationscotoma has to extend towards the direction of the retinal element that is sending that particular image. So it takes a little bit of time for the visual cortex to figure out where that is. So the processing and the latency and all that, although the exact science behind it is something that's still being explored. But you can say the processing by the central visual cortex takes a little bit of time so that Diplopia is covered a few moments later after confusion is being taken care of. But the interesting bit is, as soon as you cover the good eye and no information is being sent from the good eye back to the visual cortex, this scotoma that was formed would immediately disappear. And the person would see B and A, but now only one B and one A, because there is no comparison information. So there is no diplopia. And since the fovea is sending the information from B, you would see a very clear B and a sort of a blurry A, because A, the image of A is falling on a non-foveal photoreceptor. But the confusion in diplopia is gone because there is no information coming from the other eye. So this scotoma is really interesting, that as long as both your eyes are open, it's always going to be there. But as soon as you cover your good eye, the scotoma disappears. Interesting. That's just the way your nervous system or your visual cortex adapts to loss of binocular single vision. Let's talk about amblyopia. And amblyopia is something that would happen only in that specific age group if suppression has been around for quite some time. And that's usually months to years. And unlike suppression, which would disappear when you cover the good eye, amblyopia doesn't go anywhere. So amblyopia, even in covering the good eye, the bad eye or the deviating eye would not suddenly start seeing again. And the signals from the deviating eye would be ignored under all circumstances, irrespective if the other eye is open or the other eye is closed. And again, as we have said, that this would only develop in that specific period where the visual system is still malleable and reprogrammable, 12 years or less than 12 years of age. And that is why it is so important to manage squint at as early as possible so that amblyopia doesn't develop. And if amblyopia does develop, you'll have to do patching. And again, patching works best if your child is at an appropriate age, 12 years or less, because that's the only time where you can reprogram your visual system. So let's diagrammatically see strabismic amblyopia. This is, we left our patient off when we were talking about separationscotomas. But the difference this time is that in spite of the fact that the good eye or the orthophoric eye or the straight eye is covered, the deviating eye is still not seeing anything. In separationscotoma, if you remember, as soon as you covered the good eye or the straight eye, the separationscotoma disappears so that the eye is able to see something. But once amblyopia establishes, and specifically strabismic amblyopia, even covering the good eye will not generate any image from the deviating eye. And that is because the suppression has been around long enough to permanently sort of reprogram this visual system so as not to perceive anything. And this is basically what amblyopia generally, as we've talked about it before, and in this specific context, this is called strabismic amblyopia. So let's look at this child who has two nice straight eyes, is looking at this pair. Slightly dissimilar images fall on corresponding points on the visual cortex from corresponding foveal element, and a single image is produced. In this case, the left eye is turned inwards, Isotropia. So now what you're getting is a good image from one eye and a blurred image from the other eye, because it's falling on non-paired or unpaired retinal elements and arriving at non-corresponding points on the visual cortex. So a separationscotoma is created. And if you leave it untreated for a very long time, this separationscotoma becomes or converts into strabismic amblyopia. So now that we have understood, hopefully understood, what binocular single vision is, and what happens when you lose binocular single vision, i.e. confusion and diplopia, and how the visual system overcomes these two things by formation of separationscotoma and in the longer term amblyopia, we are going to talk about types of squint. And just so that we remember what squint was, I'm going to put the definition up again, which is a condition in which the eyes are no longer aligned to one another, i.e. are no longer orthophoric, i.e. they are misaligned. And the normal state is called orthophoria, in which both eyes are aligned with each other. There are two basic general types of squint. One is called phoria. Phoria is also called a latent squint or a latent strabismus. And this is something that only happens when you cover your eye. So if you cover one of your eyes, you are basically blocking all visual input from it. And this eye, which is not receiving any visual input, in this case, my right eye, can sort of deviate from its position because, in essence, it is visual stimulus that keeps your eyes straight. So you cut off visual stimulus, the eye can deviate from the normal position, and that is called phoria. But this is only visible when the eye is under cover. As soon as you remove the cover and the light comes back, the eye would become straight again. And this is seen during a very special test called the uncover test. We have an entire video on cover uncover test. You can see that video for more information. And we practice this in our clinic as well. So you'll be able to see how this test is done to pick up aphoria. By the implication that it is light that keeping your eye straight, if you cover a normal person's eye, which are straight all the time, for example, myself included, if I cover my eye for long enough time and I'm not converging, i.e., I'm looking at something really far off, my eye will deviate, and it does. My eye behind a cover tends to deviate outwards, which is called exophoria. And many normal people do have that. So why even test it? Well, because certain types of manifest deviation, which are called tropias, begin as phorias, and we'll talk about them when we talk about them. So tropia is a manifest squint, something that's visible when both eyes are open. And this could be paralytic, this could be non-paralytic. When it's non-paralytic, it's basically a problem with sensory fusional processes. If it's paralytic, the pathology is in the motor fusional process, which is pretty much apparent from the name of the disease. Non-paralytic and paralytic. But tropia is something which is manifest squint, which can be seen with both eyes open. And both phorias and tropias are given names according to the direction of the deviating eye. When the eye is deviating inwards, it's called esotropia or esophoria. When the eye is deviating outwards, it's called exotropia or exophoria. When it's deviating upwards, hyperphoria, hypertropia. When it's deviating downwards, hypotropia, hypophoria. And the word to describe normal eyes is orthophoria or orthophoric eyes, which is straight eyes. So this is what tropia is under binocular conditions, i.e. both eyes open, one of your eyes deviated, and this eye is deviated outwards. This little reflex is the reflex from the light that's being used to see the eyes. It's called this test to see the amount of deviation. Again, you can do that. You can see the video of evaluation of squint or strabismus in which we talk about this test. This is basically to see the amount of deviation. But right now, for our purpose, you can see that both eyes are not aligned to one another. The left eye is deviating outwards, which is called exotropia. And this is what phoria is. When both eyes are open, the eyes are straight. I cover one eye. The eye behind the cover starts deviating. And eye behind this cover, this is the left eye, which is behind the cover, has deviated outwards, which is called exophoria. Exo is for out, phoria is for latent squint or hidden squint. It's called hidden because it's only apparent when the eye is covered. But as soon as I remove the cover, this eye would move inwards or medially to take up its normal position. So the movement of the eye is opposite of the latent squint. If the eye has moved outwards behind the cover, i.e. exophoria, it would be seen moving inwards when the cover is removed. Doesn't mean that the patient has an inward deviating squint or esophoria. The eye had moved outwards behind the cover, and to get back to its original position, it's moving inwards. It's pretty simple, but you need to be able to clearly think and lucidly think without any shackles to be able to understand this. But it's not that difficult. You can just go over this slide again. There's enough description in these text boxes, and you can listen to my melodious voice as well. That's why I'm recording this. So we'll talk about non-paralytic or sensory strabismus or squint first, and we'll handle esotropia, which is the more commoner of the two deviations that we will discuss. And esotropia is a misalignment of the eyes in which one eye is deviated inwards or nasally. It is of two types, accommodative and non-accommodative. Non-accommodative is further classified into a primary and a secondary type. And accommodative esotropia is one in which, as the name suggests, there is overaction of accommodative effort. And if you remember accommodation from refractive errors, accommodation was the process in which the eye was increasing its power in order to focus for near. And there was a refractive error for distance very closely associated with accommodative effort. And I'm sure you remember which one it was. It wasn't myopia. It can't be presbyopia because that's for near, which only leaves one. That I shall not name, but will write on the screen. So this is usually seen between 6 months of age to 5 years of age. And now I'm going to speak the name. This is seen in latent hypermetropes. And latent hypermetropes were using their accommodative effort to focus clearly for distance. And in these individuals, what is going to happen is that there is too much convergence for a given amount of accommodation. Remember, accommodation reflex involve pupillary constriction, convergence, together with lens becoming more globular. So whenever these individuals use their accommodative effort, the accommodation reflex activates, so the eye also converges. Normally, the convergence isn't that great because you're looking far off, but an individual in which and only in individuals in which convergence associated with accommodative effort overacts would get accommodative esotropia. So not every child, remember this is seen between 6 months to 5 years of age, or develops between 6 months to 5 years of age more appropriately. Not seen, it can be seen much later, but it develops in this age group. Um, not every child that develops accommodative not every child who is a hypermetrope or a latent hypermetrope develops esotropia. Only those in which the accommodative effort, uh, relatively more convergence is associated with it. So the convergence associated with accommodative effort overacts, causes inward deviation. So don't think that every child who has latent hypermetropia will also have esotropia. No, only those children in which convergence associated with accommodative effort overacts would get esotropia. And this could be in one eye, or this can also alternate between one eye. So one eye, at one time, one eye is esotropic, and at other times, the other eye is esotropic. Depending upon the refractive errors, if the person has anisometropia, it would obviously be in one eye. If the person has hypermetropia, latent hypermetropia, equal refractive error in both eyes, you would have the esotropia that would alternate between the two eyes. Non-accommodative is much more simpler to understand. It's something that's usually develops from birth to up to 6 months of age, the primary form, and it's just bad sensory fusion. A secondary form happens because of some other form of decreased vision. For example, retinoblastoma or lesions of the retina that impair central vision, coarse disease, retinopathy of prematurity, toxoplasmosis. We have talked about these diseases before, and because these diseases also cut off visual signal, the eye has the potential to develop emblyopia. And one of the forms of emblyopia, strabismic emblyopia, the eye would simply deviate because there is no perception of light. So, how would these patients present? Well, the patients don't usually say anything, they're children. So the parents or the guardians usually complain that child eyes are deviating, they're not straight, and they would bring pictures to you, and that is very good because picture evidence is very good evidence. Cell phones have cameras these days, and even affordable cell phones have cameras. So they come up with pictures which tell you, yeah, the child's eye are deviating, because that's really important, because that gives you a sort of a timeline as to how long has this been going on. And the age of presentation or onset provides a very strong evidence as to the cause. If it's less than 6 months, it's likely to be non-accommodative. If it's more than 6 months, it's likely to be accommodative. Secondary non-accommodative type will have the associated underlying disease, which could be something as insidious as a cataract to any of the lesions that we have talked about. So they would have, in addition to the esotropia, those were secondary causes of non-accommodative esotropia, the features of the disease leading up to esotropia. So how do we manage them? Well, for accommodative esotropia, things are really simple. Since we know that this is overacting accommodation, all we need to do is to ensure the child does not accommodate. And for that, we give him spectacles prescriptions, cycloplegic refraction. Go back to the refractive error video discussion to review what cycloplegic refraction was, and you give spectacles. If amblyopia has set in, you would obviously require patching. And the review period is usually 6 months initially, then yearly, and then you can sort of delay it. If the squint at any time comes back, you tell the patient, oh, come back earlier so that we can check if the refractive error has changed. On each review, you need to do cycloplegic refraction. As the child is growing older, the magnitude of hypermetropia might actually decrease as the size of the eyeball is increasing, which would negate axial hypermetropia. Surgical correction is for any amount of accommodative esotropia that cannot be corrected with spectacles. It must be corrected with surgery for good vision. And it should be done as soon as possible so as to not develop or worsen amblyopia. For example, if a patient presented to you with a child presented to you with 40 degrees of esotropia and after spectacles you are left with 10 degrees, which does not correct with anything, this uncorrected 10 degrees must be corrected by surgery. We'll have a very bird's eye view of surgery at the end of this discussion. So you can see that this person was prescribed glasses, esotropia in the top picture, aligned eyes in the bottom picture. The reason that you are seeing two light reflexes is because one is the flash and the other is the light through which this the alignment is being seen. For non-accommodative esotropias, for the primary non-accommodative esotropias, it is surgical correction. Since there is no refractive error present what to speak of, so surgery is done to create a new fusional balance. And if there is any amblyopia, it must be managed pre-operatively by patching and also sort of post-operatively as well. Pre-operatively is better because it gets better results simply because there is more enthusiasm on the part of the parents. Yeah, we need to patch so that vision can improve so that surgery can be done. For secondary, we need to manage the underlying cause together with patching if amblyopia has set in. Retinoblastoma, retinopathy, prematurity. We've talked about these conditions. So retinoblastoma is chemotherapy, enucleation. If there is an enucleation, there is no question of anything afterwards because the eye is removed. Retinopathy or prematurity, vitrectomy, and Course disease have their own specific therapies. We have talked about these. But if any of these conditions was causing a squint, you manage these conditions and then see if patching is required or not. So the other type of non-paralytic squint is called exotropia that we do, the horizontal squint. In this case, the eye is now deviating outwards. So exotropia is eye misalignment in which one eye is deviated outwards or temporally, and it usually is something that is seen between birth and 7 years of age. It is again of two types, a primary type and a secondary type. A primary type can be divergence, insufficiency, or divergence excess, and a secondary type, which is happening because of another cause that is causing some form of visual disability leading to exotropia. We are now going to talk about exotropia, and exotropia is defined as an eye misalignment in which one of the eyes is deviated outwards or temporally. It is again of two types, a primary type which usually manifests between birth and 7 years of age and is further classified as either convergence insufficiency or of the divergence excess type. The other one is a secondary type. So of the primary, the first one is convergence insufficiency, which is exotropia, which is greater or which is apparent when you are looking for near. A divergence excess exotropia is an exotropia seen when the patient is looking afar. Um, the thing about exotropia that sort of distinguishes itself from esotropia, specifically accommodative esotropia, is association with refractive errors. None of the types of primary exotropia are associated with any form of refractive error, but that does not mean that a cycloplegic refraction is not done. It is still done, the protocol is still followed. But most of these conditions are almost all of the exotropias are because of some issue with the sensory programming of the fusional processes. And almost all of these exotropias begin as exophorias. And exophoria, if you remember, was a latent squint, type of squint that's seen when one of the eyes is covered. And what happens is that slowly over time, this exophoria converts into an exotropia. A secondary exotropia is one which is associated with with an other cause of decreased central vision. These causes are similar to the secondary types of esotropia that we talked about before. So we have retinoblastoma, lesions of the retina that impair central vision, Course disease, retinopathy of prematurity, toxoplasmosis, and other diseases. So this is convergence insufficiency exotropia. The picture at the top shows a girl who is focusing on a near object and both of the eyes are converging equally. The picture at the bottom shows a child in which the left eye is unable to converge properly and has sort of moved temporarily or outwards as compared to the right eye. So this is a left eye convergence insufficiency exotropia. This is divergence excess exotropia. And in this case, the picture at the top, you can see when this person is looking for near, the eyes are aligned with one another. But when this person looks afar, the left eye has deviated outwards. And I know that the left eye is deviated outwards because the light reflects from the illuminator has deviated inwards. You can see the the clinical skill, not skin, the clinical skill of evaluation of squint or strabismus, which has a fair amount of detail on this test, which allows you to determine the type and amount of squint. So how do these patients present? Well, again, as most of these patients are of a pediatric age, it's the parent or the guardian that complains that the child's eye is not straight, it's deviated, has turned outwards. And alert parents or guardians in this case would note that this problem starts off when the child is inattentive and one of the eyes tend to deviate out, i.e., when the child is daydreaming. And eventually, over a period of time, this becomes more and more permanent. So the deviation is seen at all waking hours, whenever even when the child is alert or otherwise. And that is the reason for this is that most exotropias begin as exophorias and then they convert into or evolve into an exotropia over time. And the other thing that is also very curious about this type of deviation is that when it is converting from a phoria to atropia, there are times when the eye would appear straight and there are times when the eye would appear deviated. So the exotropia is intermittent initially. And that is again because the phoria is converting into atropia and hasn't fully converted. So sometimes the child's eye are straight when he is alert, and sometimes the child's eye are deviated when he is alert. And that is basically called an intermittent exotropia. And that happens because the phoria hasn't completely converted into atropia and is sort of still in a evolutionary phase or a development phase. And if you have a secondary type of exotropia, obviously you will have features of the secondary cause of exotropia as well in your patient. So how do we manage it? In spite of the fact that this type of deviation is not associated with refractive errors, the protocol still is the same. You do a cycloplegic refraction, and then you see if the child needs spectacles. If the spectacles are indicated, they are prescribed. And if there is significant amount, or if there is amblyopia, then it is dealt with appropriately using patching. And since this type of deviation is usually not associated with refractive errors, the primary form of management is then surgery. And we'll talk about surgery at the very end once we have done all different types of squints. For secondary exotropia, it is basically the management of the underlying cause together with patching if there is amblyopia, and that is usually done once you have dealt with the condition that causes the exotropia. So if you have retinoblastoma, chemotherapy of enucleation, if you do enucleation, then there is no question of patching or amblyopia because the eye is removed. Retinopathy of prematurity, vitrectomy, coarse disease, laser photocoagulation. We have been through these conditions before when we were talking about esotropia, and we did them in a little bit of detail when we were talking about retinoblastoma. So now we're going to talk about paralytic or motor squint or motor strabismus. So this is the type of squint that happens because the nerve or the muscle is damaged, the eye is unable to move. So this can be considered to be a primary issue with motor fusion. So paralytic squints are defined as deviation of eye secondary to paralysis of extraocular muscles. And when we mean paralysis, it would also include paresis. And this could be due to lesion of the concerned nerves, which are the third, fourth, and sixth nerve, and or the extraocular muscles. They are classified as either congenital, and congenital is something that is present from birth and is usually associated with some form of birth trauma, for example, forceps delivery or some other type of trauma during the process of birth. And this type of squint is usually associated with a head turn or a head tilt. We'll just see one in a bit, or we'll talk about one in a bit. And the child basically learns to turn the head or tilt the head in a direction which minimizes diplopia. And the simplest way to remember is the head moves in the direction where the eye cannot. And this is what minimizes diplopia. An acquired paralytic squint is either of a neurogenic or myogenic origin. A neurogenic origin would include a stroke or myasthenia gravis or trauma, or myogenic would be direct trauma to the muscle, among other causes. And an acquired condition has diplopia as its presenting feature and a key feature. And it is also associated with the head turn or a tilt because the patient would simply learn to turn the head in a direction where the squint is minimized. But since this is an adult, he knows that if the head position changes, the diplopia can come back, as opposed to a child who has by habit learned to turn his head in a direction where the diplopia is minimized, because he had no way of talking about his diplopia, because he's had the diplopia, she's had the diplopia since she was or he was born, and he had no way of communicating this. So he just decided to turn or to tilt or turn the head in the direction which minimized diplopia. So the difference between the head turn or tilt between congenital is acquired is that in an acquired case, the patient can tell you, if I turn the head in this direction, the diplopia minimizes, while a child simply keeps the head turned in that direction because unconsciously he knows this is the way that produces the best vision. He will not tell you, I'm turning my head here because diplopia is minimized, because this is what his posture was since he was born, or he has learned it even before he started to speak, because this is what minimized diplopia for him or for her. So this is a child, and this child has had congenital squint since birth. Now this child is obviously older than that, and right now this child is looking straight, or has been made to look straight. So the first thing that we need to determine is what type of squint does a child have, and the type of squint that the child has is obviously, uh, I'm giving you some time to answer, is an esotropia of the right eye. So that would imply damage to the lateral rectus muscle or its nerve supply, which is the sixth nerve, which is in fact one of the more common palsies that you see as a congenital disease, or of a congenital etiology, simply because it's a very thin nerve. It runs along the base of the skull for quite a long time. So trauma is one of the causes of damage to the sixth nerve, and it could be birth trauma as well. So the second thing we need to answer is, in which direction would this child turn the eye or his head, not the eye, because the eye can't move. Which direction would this child turn her head in order to minimize diplopia? And remember, the head goes where the eye can't go. You just follow that. So if we follow that rule, the head would move where the eye can't move, and the eye can't move to the right, so the head moves to the right. So what this child would do is turn her head to the right. And since the right eye is esotropic, the left eye would turn outwards, so that relatively between the two eyes, there is no squint anymore. And this would minimize diplopia. And that is how you determine in which direction the head would be turned when a person has a congenital squint, or even an acquired squint. But an acquired squint, the patient is able to tell you. In a congenital squint, the person would simply keep the head turned in that direction because they have just learned to do it, because they've had this problem since birth. And if we were to quantify or to give a number to the amount of squint, so this patient would have about, let's say, 15 degrees of esotropia, because the light reflects in the right eye, which is shown by the yellow arrow, is at the edge of the pupil. And each millimeter of deviation is about 7 degrees. And from the center to the edge of the pupil is about 2 millimeters, which 2 into 7 is about 14. So let's call it 15. Again, if you want to know more about this, you need to see the clinical skill method of examination of strabismus or squint, or the clinical skill video of ocular alignment, which has a lot more detail into this, and it's very nicely explained there as well. So you can refer to that video. So how do we manage this? The first thing to do is to observe it. If there is no diplopia in primary gaze or reading gaze, down gaze, really nothing has to be done, because as long as the patient is looking straight, there is no diplopia, so he can simply turn his head rather than his eyes to look in other gazes. And if down gaze is the most important gaze, as it's the reading gaze, and the down gaze is fine, really observation is the way to go. Prisms, if observation is something that can't be done, there is obvious diplopia in primary or down gazes. Prisms are usually something that are stuck onto spectacles. They're sort of expensive, and they also tend to create some visual anomalies, rainbow effect, because they disperse the light. Surgery is basically the last option, but the problem is you are dealing with a muscle that has basically little or no activity, because it's either paralytic or has been paralyzed. So we operate on the counter muscle, the muscle that has the opposing action, and weaken it as much as possible so that the eyes are able to achieve single vision, i.e., there is no diplopia when the person is looking straight in primary gaze. Primary gaze is looking straight. So this is how prisms work. So this is a normal person who has no squint, so that the light is falling on the fovea. This is a person who has an exotropia, so the light is no longer falling on the fovea. So we give him a prism, and prisms divert or deviate light towards their base. So apex in the direction of squint is the rule, and the light would be deviated towards the base of the prism, so would focus on the fovea again, which would minimize diplopia. Um, for acquired paralytic squints, again, observation is the way to go. If there is no diplopia in primary gaze or down gaze, don't do anything. For neurogenic and myogenic ptosis, we give up to 6 months for recovery, simply because this is the amount of time that the central nervous system may be able to sort of recover post-stroke or post-trauma and get some of the functions back. Again, during this time, if there is any diplopia, you can give patching or prisms. Surgery if there is no satisfactory recovery after 6 months, and again, correct as much as possible to achieve single vision in primary gaze. For neurogenic ptosis myasthenia gravis, first of all, you require proper diagnosis and appropriate therapy, which is acetylcholine esterase inhibitors, pyridostigmine. Physostigmine sort of has more side effects. You can give patching or prisms as a means of reducing diplopia. Surgery is usually something that's taken or done after a lot of consideration, simply because the nature of deviation is varying. Remember, myasthenia gravis, the symptoms of the disease worsen as the day progresses, so the deviation would be changing. So it's very difficult to figure out how much of a squint to correct. So it's usually something that's taken after a lot of consideration, and if the patient is willing to take the chance of surgery as a means of correcting or managing diplopia. This is a patient of an acquired squint. He is an elderly gentleman who suffered stroke. And the first thing that you'll be asked if you're shown a picture like this is to describe the picture. Well, if you see the picture, the left eye has ptosis, and the left eye seems to be deviated downwards and outwards. Now, this eye has issues with multiple muscles, not only extraocular muscles, but muscles that move the lid. And this is a very simple diagnosis. This is a third cranial nerve palsy, because the third nerve is the only nerve that supplies multiple muscles, and it is the only nerve that supplies muscles in addition to the extraocular muscles. And thus, since you have a lid problem together with an eye motility problem, it's the third nerve. The eye is basically considered to be down and out. Now we are coming to the last part, general principles of surgical management. And surgery is something that obviously you're not going to be doing as undergraduates, but you can still explain to your patients what to expect if they come to you asking, look, we've been advised surgery, and since you are a family physician, we would like to get your input into this. Surgical correction is done for all primary non-accommodative esotropias and almost all cases of primary exotropias, as we have just discussed. And the idea is to strike a new fusional balance. And that is done by either weakening or strengthening muscles so that their forces are realigned. Muscles can be strengthened by a procedure called resection, and they are weakened by a procedure called recession. And what this does is it manipulates the torque generated by the muscle. Torque is that rotatory force. I'll just give you some very simple examples of how this is done in a bit. So recession basically means to decrease the effective force generated by a muscle, and that is done by moving it or recessing its insertion into the eye. So what you do is you take the muscle, you excise it from its original insertion, and you move it backwards along the globe, and you restitch it to the sclera. The amount of recession or to move back would be dependent upon the amount of squint, and we'll just see how that is calculated. Resection means to enhance the ability of a muscle to apply force to the eyeball, i.e., to enhance its power of contractility and enhance the torque generated by the muscle. And that is done by cutting a bit of the muscle off by resecting it. Now, it might seem very sort of strange to you that we are shortening a muscle, and shortening a muscle would mean reducing the total amount of muscle mass. So, how is it strengthening it? Well, when you stretch a muscle, you are actually increasing the size of the sarcomere. And when you increase the size of the sarcomere, actin and myosin can sort of slide over each other to a greater distance, thus increasing the active or the total amount of torque that is generated by these muscles, which is being resected. So for esotropia, when the eye is turned inwards, we would like to weaken the medial rectus, because irrespective whether it is a primary non-accommodative esotropia or an accommodative esotropia in which some of the component cannot be corrected by spectacles. The muscle that is pulling the eye inwards, although it's a sensory fusional issue, is still the medial rectus. And if I weaken the medial rectus, it would reduce the amount of torque applied to the eye by medial rectus, and it would sort of, you know, decrease its ability to turn the eye inwards. At the same time, I can strengthen the lateral rectus, which would tend to pull the eye outwards. And since the eye is rotated inwards, we want the eye to be pulled outwards. So as I said, these muscle procedures are simply realigning the forces applied by these muscles onto the eyeball. So if the eye is turned inwards, we weaken the medial rectus, strengthen the lateral rectus. Conversely, if the eye is turned outwards, exotropia, we would like to strengthen the medial rectus and weaken the lateral rectus. How much to correct is basically dependent upon which, uh, how much to correct would mean how much of recession or resection to do would depend upon the amount of squint and the muscle that's operated on. The rule of thumb is that if you're operating on the medial rectus muscle, 1 millimeter of recession or resection gives you 2 degrees of correction. That is because medial rectus is the strongest of the extraocular muscles. It works the most because most of the time you're reading or looking at near objects and the medial rectus is constantly working. So it is the most powerful muscle simply because it works the most. Lateral rectus, 1 millimeter of recession or resection gives you 1 degree of correction, and you can do about 10 millimeters of recession or resections on these muscles, medial and lateral rectus. Various texts would give you various values up to even 12 millimeters, but 10 millimeters is something that is considered to be a safe limit. Let's take the example of this case of esotropia and try to understand how the surgical procedures work. So we have 40 degrees of primary non-accommodative esotropia in the right eye. So let's make the right eye esotropic. This would mean that the eye is turned inwards, and that would imply that the medial rectus is basically acting more as compared to lateral rectus to keep the eye pulled inwards. That's why these 3 plus symbols here. Now, in order to correct 40 degrees of esotropia, we need to do obviously muscle surgery or surgery on the muscles. And since the eye is turned inwards, we want to weaken the medial rectus and we want to strengthen the lateral rectus. Weakening procedure was recession, and the strengthening procedure was resection. How much to do? Well, since we have 40 degrees of esotropia, we would need to correct as much as possible. And the limits of our surgical procedures were 10 millimeters. So if we do 10 millimeters of recession and resection on these muscles, for medial rectus, we get 20-degree correction because remember, medial rectus, every millimeter of recession or resections give you 2 degree of correction. For lateral rectus, it was 1 millimeter giving you 1 degree of correction. So the total correction by this is 30 degrees. So what we did was we moved the medial rectus backwards to recess it. We made the lateral rectus shorter by resecting it, and that gave us 30 degrees of correction. So now we have 10 degrees of non-accommodative esotropia left. Our medial rectus is still sort of overacting, but not as much as before. Our question is, my question is, how do we correct this 10 degrees of residual squint? What do we do about it? Where do we get it from? Remember, this is non-accommodative esotropia, so you just can't give this patient spectacles and be done with it because spectacles are not going to do anything. Think, think, think. Well, you can think. Pause the video and think. I'll give you the answer now. So, for this non-accommodative esotropia of 10 degrees, which is left residual, what we can do is we can do surgery to the left eye. What if I weaken the medial rectus of the left eye by 5 millimeters? And since surgical procedures on medial rectus gave 2 degrees per millimeter, I would get 10 degrees of correction if I do medial rectus recession of 5 millimeters. That would weaken this medial rectus and move the eye outwards because the lateral rectus would now be stronger by 10 degrees. So our right eye is turned inwards 10 degrees, esotropia, and our left eye is now turned outward 10 degrees, exotropia. So relatively between them, there is no squint left. I know this is a very difficult concept to understand and grasp. I mean, imagine how would it be to explain it to patients that, we need to do surgery on an eye that's looking straight and you're doing it on a child mostly. So the parents or the guardians are going to say, why do you want to touch the good eye, the straight eye? So that is why when you have excessive amounts of squint that it cannot be corrected by surgery on one eye, you do a stage surgery. You do surgery on one eye, telling the patients prior to even doing the first surgery that maybe we'll need to do two procedures. Then you show or you explain to the parents or the guardians or the parent or the patient, if the patient is old enough, look, this is the correction we have when we have operated on one eye. Let's take it back to one eye. So this is amount of squint left, 10 degrees. And if the patient is satisfied, you just leave it as such. But if the patient says, no, I want more, and that should be it, because unless the eye is straight, especially in a child, amblyopia therapy is not going to work any well because the light still isn't falling on the fovea properly, and you would still get diplopia and confusion. Confusion sort of is, and you'll still get that scotoma that covers diplopia and confusion. So you would explain to them that we can leave it here, but that would imply that the vision will not develop. So we need to do the surgery to the other eye in order to get the best results. Many times, in the case of children, the parents would agree. But in case of adults, this is usually not the case because in adults, you usually cannot guarantee visual improvement because that person has passed the cutoff age for amblyopia therapy by patching, because patching doesn't work, mostly doesn't work once the individual is more than 12 years of age. So adults may sometimes say, oh yeah, prior it was 40 degrees, now it's 10 degrees, it's doable. But in children, it is highly recommended that you convince the parents or the guardians to get complete correction done so that the amblyopia therapy could improve vision in the eye, because then relatively between the two eyes, there is no squint. So the eyes can sort of readjust and form a new fusional balance between the two of them. So this is what it's done. We do medial rectus recession 5 millimeters to the left eye, so that now our net result is orthophoria. So for the left eye, the lateral rectus as compared to the medial rectus is working a little bit more to counteract the effects of the medial rectus in the right eye, which is sort of working more. So the opposing muscle working a little more makes the relative squint between the two eyes as nothing. So the eyes apparently look straight again. Yes, that is how crazy squint surgery can be at times. So, what are the complications of surgery? Usually, they're very safe, provided that you have an experienced surgeon. It's usually that you have under or over corrections, which is called consecutive squint. Consecutive squint is you started off with an esotropia, you ended up with exotropia. Rare, but it is possible to get it. And in this case, recession procedures are usually easier to reverse because all you did is change the muscle position, so you can go back and review your recession. Resections cannot be reviewed because unfortunately whatever muscle portion you have cut away. That is why it is usually recommended that if you have the choice, do recessions before resection. Globe rupture, sometimes when you're cutting the muscle, you can cut the globe, which would require the assistance of a vitreoretinal surgeon to appropriately manage. An ischemia of the eyeball, since the blood supply to the anterior part of the eyeball travels along the horizontal and the vertical recti muscle to an extent, doing surgery to multiple muscles in one eye can actually cause ischemia of the eyeball. It's rare, but something that's still possible. So thank you very much. That's it for squint. I know it's sort of a more challenging topic as compared to others, but if you pay a little bit of attention, it's not all that difficult. You know where to ask questions. I hope you've had fun during your ophthalmology clerkship and you were able to complete your learning objectives, i.e. gain the competence that we have outlined for you at the beginning of the course. And you are free to review these sessions as much as you want. They're available to you. And if you have any questions with this on this topic or any other topic, you know where to post. Thank you very much. Bye bye.